luspatercept has it's just a short kind of time horizon here, but has a storied past going back, many, many years. The first, I'd say, enthusiasm, for the use of this product came from the Medalist trial, which was looking at patients with low risk MDS, who in this case were refractory to ESAs or erythropoiesis-stimulating agents, or patients who were unlikely to respond to such based on a baseline serum endogenous EPO level, and that trial was 200 or greater. And the responses were great. This was a placebo-controlled trial, and this realization prompted the COMMANDS trial, which was the phase 3 randomized patients, in this case that were patients who had red blood cell transfusion dependent, but in this case ESA naive patients 1-to-1 to get luspatercept or ESA. The primary endpoint was undoubtedly achieved, 60% versus 30% in favor of luspatercept. Primary endpoint in this case was at least 12 weeks transfusion independence across a number of subgroups important to getting to your question, including most pertinently RS positive disease, low EPO, low transfusion burden. These latter two, so having a low EPO and a low transfusion burden, prompted, I think, enthusiasm for ELEMENT. So what about introducing this effective agent before a patient becomes red blood cell transfusion dependent, which is actually the majority of patients with low risk MDS at diagnosis? This is what ELEMENT-MDS is attempting to answer. It's a phase 3, another randomized trial looking at luspatercept versus EPO, and really reducing the progression to transfusion dependence in ESA naive, non-transfusion dependent patients with low risk MDS. Low risk defined using what we generally call the revised IPSS. This trial excludes low risk MDS with deletion 5q. And as you would otherwise expect to randomize a patient to an ESA, you have to have a pretty low baseline EPO level. It's less than 500 in this trial. Stratified by, I believe, 3 important factors: baseline EPO level, RS status, a key indicator of who is likely to respond to this agent, and then IPSS risk category. This trial does include intermediate risk revised IPSS patients, about 20% of all low risk MDS. And this primary endpoint is a 16-week red blood cell transfusion dependence up to week, I think, just shy of 100, if I recall. So this is the right trial to do. It's an effective therapy, tends to work for patients who have low EPO, low transfusion burden. So you could just posit, and I think that there's good confidence that if you use it earlier, it's going to work better and really prevent patients from becoming transfusion dependent. At least that's the theory. And theoretically stalling the time by which they accumulate this significant transfusion burden, which predicts a non-low risk of iron overload, which associates with morbidity. And just taking it maybe 2-3 steps further might actually increase the risk of a stem cell transplant being safe if iron overload is one of the main issues that predicts lesser or worse post-transplant outcomes.